Introduction to Down syndrome. What is Down syndrome? Babies are born with chromosomes. Having Down syndrome means that there is an extra chromosome. Down syndrome is very common. Approximately 1,000 babies are born with the syndrome in this country each year. It occurs in all races, all religions, and all social classes. A diagnosis of Down syndrome is not in any way predictive of the ability of the child, and Down syndrome is not an inherited condition. There are over 40,000 people in the UK with the condition, and today the average life expectancy for a person with Down syndrome is between 50 and 60, with a small number of people living into their 70s and beyond. Parents of children with Down syndrome come in all ages. Although the incidence of Down syndrome births increases with older parents, these parents over 35 are routinely offered screening. Younger parents are not screened, and so it is now unusual to find young people with children with Down syndrome. It occurs most frequently, but not exclusively, in children born to mothers over the age of 35. Down syndrome statistics. A 25-year-old woman has a 1 in 1,200 chance of having a baby with Down syndrome. By 35, the risk has increased to 1 in 350. By 40, it is 1 in 100, and by 49, it is a 1 in 10 chance. Every person with Down syndrome will have some level of learning difficulty, but it varies from person to person. Physical features include short stature and a broad facial profile. Physical characteristics: a smaller nose, ears smaller and lower, mouth smaller cavity and weaker tongue and mouth muscles, hypertonia, smaller hands, and hypermobility. Nose: they usually have a soft bridge and find it hard to keep glasses on. Ears are small and lower down, a small mouth cavity and weaker mouth and tongue muscles. Eyes: this includes upward slanting of the eyelids, prominent folds of skin between the eye and the nose, and the small white spots present on the iris, the coloured part of the eye, called Bushfield spots. These spots are harmless and can be seen in people without Down syndrome as well. The shape of the eyes, no impact. Hypertonia, floppiness due to reduced muscle tone. This physical characteristic is common among many, but not all babies with Down syndrome. It affects every baby differently. Can't clear nose easily. Colds last longer. Palmar crease, a single crease across the palm. This physical characteristic is common among many, but not all individuals with Down syndrome. It is also found in the general population. Respiratory: the upper airway in individuals with Down syndrome is narrower, and there are also some structural differences in the lower respiratory tract and within the lung tissues. These differences, combined with low muscle tone, may predispose them to developing infections. The immune system in individuals with Down syndrome is also thought to be slightly different. Hands: fine motor skills, building a tower. Typical development is around 15 months. With Down syndrome children, it's around 30 months. Speaking: 2-word phrases is typical around 20 months. With Down syndrome children, 30 months, and sometimes up to 5 years. Walking: typical development around 12 months. Down syndrome children around 23 months, some up to 4 years. And toileting: typical development, bowel control for 2 years. Down syndrome children, 3 years to 5 years. Strength areas: they have good social skills and social understanding. They have good self-help and daily living skills. They have good visual short-term memory, and reading is an area of strength. They remember things more easily when they are presented visually. Kinesthetic learner: hands-on experiences are repeated. Social life, clubs, after school helps to support social skills. They learn by good positive role modelling and make better progress if introduced to lots of clubs and social activities, such as learning an instrument, joining a dance group, playing football, etc. Communication. They have a smaller mouth cavity and weaker mouth and tongue muscles, which might make it harder for these children to physically form words. Most children will start to speak between the ages of 2 and 3. Receptive skills are generally greater than expressive skills, and as a result their cognitive skills are often underestimated. Total communication, objects of reference, photos, gestures, Makaton commencing with functional communication, and make personalised keyword picture books for them. Supporting communication. Use simple, clear instructions appropriate to the child's level of understanding. Give one instruction at a time. Support the spoken word with visuals, gestures and signs, and allow the child time to process what you've said. Offer clear expectations and be consistent. Get down to their level and use the child's name and cue them in. 2 key words is that their level of understanding, such as James, bag. Give an instruction, wait for them to do it, then call them back for the next instruction. Use Makaton, gesture and visual cues appropriate to the child's stage of development. Allow up to 10 seconds, then repeat, don't rephrase. Speech and language advice. Make sure child knows exactly what to do and what will happen if they don't do it. Don't insist on eye contact. Some children find this uncomfortable. Other ways to check they're listening, so they may turn towards you or stop what they're doing. A brief glance are all okay. Behaviour is a form of communication. Look for it and try to work out what they're trying to tell you. Choices help children to feel in control. Provide ways for them to get involved. Use their interests and small groups and quiet spaces. Using visuals. Most children with Down syndrome are visual learners and will benefit from visuals to support understanding and learning and to develop their independence. This is good practice for all children. Visuals. They enable the child to see the task as the visual remains in the brain longer than the spoken word. Give the child more time to process information. Enable child to sequence and practice new skills, and reduce anxiety by giving children predictability. Vision. 70% of children with Down syndrome have some kind of visual impairment. They are also slower to move their focus from one visual stimulus to another. Visual processing is a strength whole word, reading, introduced at an early age. Visual materials can be looked at as long as necessary for a child to process. Eye infections and watering eyes tend to be more common in people with Down syndrome, and the local authority have a visual impairment team if needed to find out more information. Glasses. The need for glasses is much more common in children with Down syndrome than in the general population. This refractory error can be a long-sightedness, astigmatism, or short-sightedness. Another problem is difficulty changing the focusing power of the eye from distance to near. Trying to keep the glasses on can prove to be very difficult due to a soft, smaller bridge of their nose. Hearing. Glue ear affects up to 85% of children with Down syndrome. This will affect hearing levels and concentration and may mean that they only hear parts of the words. If they do not hear, they will not store accurate representations in their memory systems. Poor auditory short-term memory skills and poor auditory processing skills. Hypoacusis, which is a sensitivity to noise. They may wear a hearing aid, and local authority have a hearing impairment team if needed. Fine and gross motor skills. Gross motor skills develop in the same pattern with some delay, reaching milestones later. Many children with Down syndrome have low muscle tone, hypotonia, and loose ligaments. The thumb joint can be particularly lax. This may impact upon the acquisition of fine motor skills and writing skills. They may have sensory processing differences, and their motor neural pathways seem to be relatively ineffective or inefficient and take longer to become established. They provide additional practice of motor skills. What is sensory processing? We take in information through our senses all of the time. Our sensory system interprets the information and attempts to make meaningful and appropriate responses. We then attempt to filter out the information we don't need and keep the information we do need. Our senses. Obviously there's sight, sound, smell, taste and touch, but there's also interoception, proprioception and vestibular. Remember, each child with Down syndrome is different. Each child has a specific learning profile. They have their own personality, strengths and weaknesses, and children with Down syndrome learn well in mainstream with appropriate provision. Strategies. Place the pupil near the front of the group. Use of simple language. Use visuals presented simply and clearly. Processing time for visual information. Limit the amount of verbal instruction at any one time. Allow time to process and respond to verbal input, as they may have a weak auditory memory. Get visual attention before asking them to speak. Reduce background noise, and outcomes modified and demonstrated. Clear classroom organisations and routine. Behaviour. Children with Down syndrome may present behaviour similar to those seen in typically developing children of a younger age. Behaviour is an effective communication. Remember, because children with Down syndrome are coping with many more difficulties than most of their peers, they could become anxious or frustrated more easily. Children with Down syndrome experience failure more often than other children, and it may be because of this that they often begin to avoid tasks which they perceive as being too difficult. Make sure the rules are clear. Ensure that all staff are firm and consistent at all times. Agree the name of a key person who will act as first point of contact in cases of difficulties. Distinguish the can't do from the won't do. Investigate any inappropriate behaviour, asking yourself why the child is doing it. Ignore attention-seeking behaviour within reasonable limits and catch them being good and praise them. Reinforce the desired behaviour immediately with visual, oral or tangible rewards. Make sure the child is working and playing with peers who are acting as good role models. Reducing stress and anxiety. Try some of these. Tummy breathing, visuals or gestures and signs, offer choice, adult support, calm safe space, heavy work, transition object, relaxation techniques, routine, or a calm down book. Thank you for listening. Please subscribe to the channel. Thank you.